This program contains graphic images and discussion of medical procedures. Viewer discretion is advised. IRAD, or International Registry of Acute Aortic Dissection, is a observational cohort study, inception cohort study of patients with aortic dissection. And today we're going to focus on what some of the things we've learned from IRAD, or think we've learned, as was pointed out by the moderator, who actually pronounced my name correctly, which is really impressive. And if I can go forward, these are my disclosures. I've done a lot of consulting for anticoagulant makers. It has nothing to do with this talk. Further, I'd have to disclose in the interests of full disclosure, I am a board-certified internist, which means I have too many slides, and I'm undoubtedly going to mess up the schedule, but I'll see what I can do. So this is IRAD today. It's up to 50 active sites. It started with 3 people, Kim Eagle at the University of Michigan, Eric Isselbacher at Massachusetts General, and Christoph Nienaber in Rostock, Germany. They thought we could learn more about aortic dissection if they were to pool their cases and see what we could learn. So we're now up to 50 actively enrolling sites, and we actually have 30 more in various stages of applying to be a part of IRAD. This is our total currently. We've enrolled 7,303 aortic dissection patients. Again, this is an inception observational cohort. Patient comes to the hospital with aortic dissection, they're enrolled. There really isn't anything more in the way of exclusion or inclusion criteria. About 2-to-1 ratio of type A's to type B's, and today we're going to focus on the type B aortic dissection. So let's review some of the data we've presented and published. Now, these papers were published at different times in IRAD's existence, so the number of subjects has obviously varied dramatically. Also, the number of subjects for which we can make the analysis in question varies from time to time. So let's review some of the demographics and past history. And comparing type A and type B, there are minor differences, such as a trend towards increased age, increased hypertension in type Bs, and we're going to come back to that because that's actually important. Surprisingly, and this has been consistent for 20 years now, there's actually a greater likelihood of a history of prior heart surgery in the type Bs than the type As. As far as presentation, there are only minor clinical differences. Almost all our patients have pain in terms of where they have the pain. One striking difference between type A's and type B's is much more likely the type B's to have back pain. And as you would expect, the type A's are more likely to have central symptoms such as syncope in terms of presenting symptoms. In terms of physical exam findings, again, the type A's are much more likely to have, as you would expect, things that pertain to tamponade, aortic insufficiency, or shock. So they're much more likely to present with an AI murmur, with a pulse deficit. And as I said before, the type Bs are much more likely to present hypertensive, in fact, dramatically so. And again, we're going to come back to this because it's interesting epidemiologically. So this is a review paper we published about 2 years ago. I wasn't involved in this analysis, but it looked at the IRAD experience in toto up to 17 years at that time. A couple of interesting observations. We divided it up into sextiles in terms of time frame. And as you can see, there's a steady, inexorable, highly statistically significant improvement in type A outcomes. And that's in spite of the fact that, or maybe because of the fact that, we're operating on these people more promptly, which I didn't show in this slide. Frustratingly, when you look at the type Bs, there's really been very little change over the last 17 or 20 years in terms of in-hospital mortality, which has really hovered around 10%. Drilling down on the type B data, these show what you and I all know, what's been happening in terms of the treatment of type B dissections. Fewer and fewer are getting medical management only. The green bar is shows a significant increase in those who are getting endovascular treatment, and the blue bar is a significant decrease in those who are undergoing open surgery. There is no associated change in mortality at this point. Obviously, these are observational data. More than a decade ago, we confirmed some of the adverse outcomes that are seen in patients with type B who have complications. And this stands to reason. If someone has limb ischemia, visceral ischemia, or frank rupture, obviously the mortality is going to be striking. And in all of these groups, it's at least double the average and maybe higher. What was fascinating and continues to be fascinating to me is refractory pain and refractory hypertension alone are significant negative prognostic factors. The subsequent paper, we drilled down on this in much greater detail. This is Santi Tremarchi in Milan led this analysis. We compared only two groups for this analysis. Those in low risk, no complications, and those at intermediate risk who had only refractory pain and or refractory hypertension. And as you can see, just having one or both of those risk factors dramatically increased the in-hospital mortality, and if they were managed medically, tripled the in-hospital mortality. And this is from 2010, so the data were up to about 2008 or 2009 to be pulled for this analysis. So this was followed up a little more recently by an attempt to identify more broadly, what are the risk factors for a bad outcome in type B dissection. This paper was actually co-authored by Jip Tollenaar, one of our Dutch PhD students, and not I, Whit Freilich, who is my oldest son, was an undergrad at Amherst when they co-wrote this paper. I forgot to disclose that I have an over-exuberant paternal pride, sorry. And this just shows the breakdown in terms of mortality by medical treatment group in 2014, so this is probably 2013 data. Surgical mortality double that of endovascular, which at that time was not statistically different from the medical treatment. So what they did was they drilled down on presentation factors that might be associated with bad outcome, and of course they're the usual culprits: spinal ischemia, mesenteric, renal failure, hypotension, or limb ischemia. Complications that developed in hospital that were predictors of bad outcome, and that mostly amounts to syncope, hypotension, and shock. And they put together this prediction model. So these are the coefficients in the model, and these are the risk factors that are associated with a significantly increased in-hospital mortality for type B aortic dissections. This is an inception cohort, and they derived the risk score here. To my knowledge, we haven't validated it yet, so anybody who has a database they want to work with us on to validate this risk score for type B in-hospital mortality, we'd be interested. This is a more recent cut of the data which shows similar trends. Overall mortality about 10% in 1,500 type B aortic dissections. Those undergoing endovascular treatment, 12%. Surgical mortality has gotten somewhat better, but the numbers have gotten dramatically smaller as most are managed either medically or endovascularly now. So let's transition to chronic care. So we tend to think about aortic dissection as a surgical emergency, of course, but we've looked in our database at ongoing care for patients with type B aortic dissection, and I want to point out something from this early study about a decade ago that showed that among survivors who leave the hospital alive after type B aortic dissection, in 3 years there's about a 20 to 25% mortality. So this is a high mortality chronic disease once they leave the hospital. Toru Suzuki, who was one of our IRAD investigators at the University of Tokyo, who's now at University of Leicester in England, he and I looked at chronic medical therapy and to determine if there were any associations between type of medical therapy and outcomes. We actually were hoping and expecting to find that ACEs and ARBs were dramatically better. And what we found for the type Bs was actually not that. Calcium channel blockers were the only drug that was actually associated with a significantly decreased mortality after hospital discharge in type B aortic dissection. And this stands in contrast to our data for the type As, where beta blockers are significantly protective long-term in survivors after they go home from a type A dissection. The confidence intervals are wide here only because almost everybody gets a beta blocker, and we actually had a small comparison group. So Frederik Jonkar, another one of our Dutch PhD students, did a further analysis to look for factors that might be associated with subsequent post-discharge expansion of a type B aortic dissection. And what he found was calcium channel blockers were not only associated with mortality, as we found, but also associated with less likelihood of expansion. And he drilled down on multiple factors and found a couple of interesting things. Small aortic size in the type B dissection survival is actually associated with increased risk of expansion subsequently, as is white race. Not a good comparison because we had only small numbers of non-white subjects. Intramural hematoma was associated with a decreased likelihood of expansion, as was female sex and, again, calcium channel blocker therapy chronically. I'll close with just a couple observations about age and size. This is the age distribution of our patients with type B aortic dissection, skewed a little bit towards the right compared with the type As. And this is trends over age in terms of type B aortic dissection management that we observed. As one might expect, the older the patients, the less likely they were to get either open or endovascular intervention. Interestingly, the mortality also goes up with age, not surprisingly, but that didn't seem to vary in terms of how patients were managed initially. Size of aneurysm. So what we looked at for this analysis was once a patient presented with a type B aortic dissection, we had the size of the aorta at the time of presentation. And we've looked at that. And we previously had also published data looking at the type As, which showed that a lot of people dissect when their aorta are not all that big. And we found the same thing with type Bs, but also some significant differences between those who had an aorta less than 3.5 centimeters when they presented with dissection versus those who had larger aortas. One is, for those with a more normaloid size of their descending aorta, there actually were many more women than in the larger aortas. And interestingly, prior aortic surgery, CABG or cath were all associated with a greater likelihood of dissecting at a small size. Again, these are observational data, so they don't really imply anything in terms of causality. This is an interesting graph that shows the relationship between size at the time of type B aortic dissection and the gender breakdown. And there's a male predominance through all of these until you get down to aortas that are less than 3.5 centimeters, where the male to female ratio is basically completely even. I don't know why. And then finally, as kind of a teaser to the subsequent discussions, we did publish a long-term follow-up. Rossella Frattori in Italy led this analysis, comparing long-term outcomes in patients who underwent endovascular versus medical management in type Bs. And as you can see in our data, over the first year, there's virtually no difference. Obviously, these are not randomized, they're selected, but interestingly, over time, there appeared to be a significant survival benefit to having had an endovascular treatment for your acute type B. And I think that'll lead into some comments later in this session by others. So I'll end by just saying, oops, I went backwards, sorry. Disease is very old. Nothing about it has changed. It's we who change as we learn to recognize what was formerly imperceptible, as Charcot said. And I'll end there. Thank you.
Yes, we have a few minutes for questions. Any questions? And I don't want to pronounce your name because I'll give it a Puerto Rican twist, and that's probably not good. Any questions?
Well, so on this problem with intractable pain or hypertension, so typically that wouldn't necessarily be something we would focus on in terms of treatment. Would you say that those patients likely should be treated endovascular? And if so, how long do you, if someone comes into your hospital, how long do you let them sit there in pain or with their blood pressure on 2 or 3 drugs before you treat that?
Yeah, those are really good questions. How long is intractable? If you're having the pain, it's any 5 minutes, of course, and you guys deal with this much more often than I as surgeons. When do you pull the trigger? As I've said, I find that fascinating. I suspect it's telling us something that we're either not imaging enough to catch, or we're not imaging enough with enough fidelity to catch. Something is going on to cause that pain. Maybe it's pressure in a false lumen, maybe it's continued expansion, I don't know. We tend to be pretty aggressive in those patients if we can't control their blood pressure or their pain. How long is too long? I don't know. And I suspect people in the audience have a better opinion about this than I.
Can one separate intractable pain from refractory hypertension? Because most patients with intractable pain are going to have hypertension.
I agree. I suspect they're related, and I can't remember how it broke out in that paper, how many had only one or the other. But as you saw, hypertension is much more common in type Bs, and it's not a good thing.
Yes.
Thank you for your talk. I just was curious how the IRAD registry defines internal hematoma extending the arch or dissection involving the head vessels. Is that considered type B? If you can clearly see an entry tear at the type B area and there's no ascending involvement. Anecdotally, at our group, the cardiac surgeons have started to treat that much more conservatively. Therefore, they're type B, and the mortality rates are, in my opinion, different. And so does that cloud that kind of data?
I agree. We've been debating that for ever since the registry began. We have included the type that you describe, I'm pretty sure, those who have an entry tear in the descending aorta but with some retrograde dissection into the arch. We've included them in the type B group. And we actually wrote a paper that I was not a part of, looking at the effect on outcomes of arch involvement. I think Tom Tsai, who's at Kaiser in Denver, wrote that paper. And as you might expect, not good, but not the same as the ascending group.